Okay, well, hello, good morning, everyone. My name is Armando Martinez. I'm currently doing my social service in the Universidad Autónoma de Baja California in Mexico. That's what the MPSS means. And I'm going to be talking about a condition called cerebellar cognitive affective syndrome. First, we're going to start talking about the general anatomy of the cerebellum. We can talk about the anatomy of the cerebellum in two different divisions. We can talk about an anatomic division, which is divided into lobes. We have the anterior lobe, which is in itself divided into lobules from 1 to 10, the posterior lobe, and also the flooconodular lobe. We also have some functional divisions, which include the spinocerebellum, which mainly communicates, as the name says, with the spinal cord. We also have the cerebrocerebellum, which has many cortical inputs and outputs. And we have the vestibulocerebellum. Each of these parts of the cerebellum has some nuclei.
It's off.
Dentate nuclei, which is going to be very important. We're going to see in the next slides. And the vestibulocerebellum doesn't have nuclei by itself, but it's going to communicate with the vestibular nuclei in the medulla oblongata. Okay, we're also going to talk about some anatomo-physiological correlation. We're going to mean posterior lobe. The motor functions are mainly going to be located in the anterior lobe, and a part of the lobule number 8 is going to be a part, usually in the medial part of the posterior lobe. The limbic cerebellum is also going to be distributed along the posterior cerebellum, and the vermis. Actually, some studies have shown that stimulation of the vermis generate changes in some areas of the cingulate cortex, the hippocampus, and the amygdala. So we're going to talk first about Schmachmann syndrome. Schmachmann syndrome is an eponym to talk about cerebellar cognitive affective syndrome, and it gets its name from Dr. Schmachmann, who first described the condition in 1998. In his first study, he analyzed 20 patients with cerebellar conditions, various cerebellar conditions. Some patients had isolated cerebellar conditions. Some patients have global conditions like spinocerebellar ataxias. And he saw deficits in 5 main areas: visuospatial performance, executive function, linguistic processing, regulation of affect, and distractibility. Further studies have shown that the most important of these 5 parameters are the first 3. Actually, I'm going to talk later about a meta-analysis that was done 2 years ago, and they actually found no difference in distractibility and attention deficit compared to controls. But there's a little bit of, how can I say, difference between the different studies that have been made because of small sample sizes and the such. And Dr. Schmachmann based his theory around 2 different theories. The theory of dysmetria of thought, that basically states that just as the cerebellum, it controls and plans motor movements, it can also do the same for cognitive and affective functions. And the universal cerebellar transform, that basically stated the cerebellum universally controls parts of the central nervous system. And we could consider the cognitive and affective functions as the 3rd element of clinical ataxiology. I'm going to be talking a lot about Dr. Schmachmann, and so I included some of the landmark studies or dates regarding this condition. The first study by Dr. Schmachmann was in 1998. He has since then published more studies on cerebellar cognitive affective syndrome and cerebellar mutism syndrome. In 2015, the Posterior Fossa Society was founded, whose main function is to study and develop guidelines for the management of cerebellar mutism syndrome, which I'm going to talk more into detail in a few slides, and recently cerebellar cognitive affective syndrome. A specific scale was developed by Dr. Hosch and Dr. Schmachmann in 2018, which was in itself evaluated in meta-analysis in 2019. And the most recent big study was a task force by Dr. Argyropoulos in 2020. So talking about the cognitive cerebellum, cerebellar cognitive affective syndrome has 2 main phases. Cognitive elements and affective elements. Unfortunately, most of the studies have focused on the cognitive elements, so there is much more information on the cognitive elements. The first mention of a cognitive function of the cerebellum was by Vincenzo Malacarne in 1776, who first studied the relationship between cerebellar size and intellect in different patients. As I already mentioned, these are the main three affected domains. Multiple studies have shown that there are changes in the cerebellum in different degenerative conditions, including Alzheimer's disease, as you can see, mainly in the posterior cerebellum. Also in ALS, that is particularly related with frontotemporal dementia, as well as other Parkinson plus syndromes like progressive supranuclear palsy and multiple system atrophy. Also, some studies have shown in multiple sclerosis that lesions tend to be located on the cerebellum. They are located on the cerebellum, so are particularly located on the midline and on non-motor areas. So patients with multiple sclerosis can also develop cognitive and affective changes. This is an example of two tests, resting state functional connection MRI and a task-based MRI. The resting state functional connectivity mainly tells you the connectivity between different areas of the brain and the cerebellum. In this case, you can see that here in the motor area, the connections are mainly, as I told you, in areas 8 and the anterior cerebellum, while other areas like here on the cingulate cortex, they are mainly located in the posterior lobe. And also you can also see in the task-based activation studies that motor areas activate mainly the middle cerebellum, while the posterior lobe is mainly involved in language processing and visual spatial processing. This is a different task-based MRI that uses meta-analysis, a case study of a particular patient and a group study of 9 patients. And as you can see, the results are pretty similar between motor, language, spatial, and working memory, with most of the motor areas being in the anterior lobe and region 8, and the others being concentrated mainly on the posterior lobe. I've been talking a lot about the posterior lobe, but it is also important to know that some non-motor functions may be located in the anterior lobe, and some motor functions are also located in the posterior lobe. Some other studies by Dr. Heath and Dr. Moriguchi actually studied patients with cerebellar disease and schizophrenia, and they found a correlation between schizophrenia and some cerebellar changes. Okay, they also found a relationship between cerebellar disease and epilepsy. Most of the studies, unfortunately, for our present topic, of patients with cognitive function deficits in cerebellar disease have actually been done in patients with spinocerebellar ataxia and other different types of generalized central nervous system diseases. So it can be difficult to know which of the deficits in the patients are actually due to problems with the cerebellum itself or due to the problems of the entire central nervous system. And here, just as a matter of reference, I put some of the spinocerebellar ataxia types. And as you can see, they are particularly related with cognitive deficits. Spinocerebellar ataxia 13 with mental retardation, spinocerebellar ataxia 17 with dementia. It's one of the parts of the spectrum of spinocerebellar ataxia number 17. Now talking specifically about the limbic cerebellum, there are much fewer studies for the reasons that I already mentioned. Dr. Combet first reported emotional disability in a patient with cerebellar agenesis in 1831. A condition that I mentioned earlier was cerebellar mutism syndrome. This is a condition that occurs usually after surgery to the posterior fossa, most commonly medulloblastoma surgery in children. And it usually presents with initial mutism 1 to 2 days after the surgery, evolving to dysarthria and some other cognitive and affective changes. It has been seen that emotional lability is an important part of cerebellar mutism syndrome, and some authors have hypothesized that actually cerebellar mutism syndrome and cerebellar cognitive affective syndrome are on the same spectrum. That is why the Posterior Fossa Society is now studying both of them. And there are many different changes in affection. On Schmackman's original study, for example, they saw many obsessive compulsive behaviors, but the most prominent aspects are emotional lability and depression. Now, as I mentioned, anterior and posterior, the anterior and posterior lobes have varying functions. That is why some authors have also wanted to go to what we know as voxel-based mapping. What this basically means is that they're going to use voxels, which are basically arrays of data from an image file of an MRI in order to better delineate lesions. It is also important that these studies be done analyzing both the cerebellum, for example, you can see here the cerebellum, and parts of the central of the cerebrum, because studies have shown using this methodology that lesions to the cerebellum can have impacts to non-lesion areas in the cerebrum that have important connection with the cerebellum. This particular study is going to, well, it used BLSM, which is voxel-based lesion system mapping, in order to see how the lesions are going to be seen in patients that have depression and patients that are not depressed. And you can see that patients that are depressed have more lesions on the posterior lobe, while non-depressed patients usually had minimal lesions on the posterior lobe. Now, here is another type of study. This is not voxel-based mapping, it is a SPECT, and it is a particular SPECT of a patient, a case report of a patient with a right cerebellar infarction. And the interesting part is that you can see here the cerebellar infarction, but you can see that there are changes, but you can see 2 standard deviations from the mean in the left frontal cortex, in the left prefrontal cortex. So as I mentioned, changes in the cerebellum can have impact to changes in other regions of the cerebrum, even if they are not directly affected. So I've talked a lot about the investigation. So clinically, what is cerebellar cognitive affective syndrome? CCAS is an extensive array of cognitive symptoms and affective syndromes that have a cerebellar pathology. The severity of the symptoms has been correlated with the lesion size, the presence of unilateral versus bilateral lesions, and acute versus chronic lesions. The spectrum is going to involve 3 main functions, as I mentioned earlier: language, visuospatial function, and executive function, which includes verbal memory, working memory, etc. Interestingly, studies of cerebellar mutism syndrome in patients with tumors have not actually shown a correlation between the tumor size and the presence of the syndrome or the severity of the syndrome. Talking specifically about language changes, one of the most interesting parts of the syndrome is that it causes alterations in grammar, in prosody, naming, syntax, and metalinguistics. It has a particular tendency to affect abstractions, and, and it also has a tendency to affect more phonemic fluency than semantic fluency. In most of the studies, they evaluated phonemic fluency with the WMS test, which is basically tell me all the words starting with the letter M that you can in a minute, for example. And semantic fluency, they evaluated with the animal test. Tell me all the animals you can tell me in a minute. So here's an example from one of Schmackman's studies of ambiguous sentences in patients with cerebellar disease. So you can see, for example, the roar of the fans disturbed the team. The white teams lost and the fans roared. The coach was thrown out. So what these sentences basically show is that these patients have difficulty with interpreting ambiguous sentences. So they usually interpret them literally, and they have difficulty abstracting the meaning of those kinds of sentences. As I mentioned, there is a relationship between CCAS and posterior fossa syndrome, or CMS. Posterior fossa syndrome and CMS are synonyms. CMS was originally conceived as a transient period of mutism followed by dysarthria with varying distributions. It was usually described as a transient condition, but many studies have shown affective and cognitive problems on the long term in these patients. Usually, patients have medulloblastoma, but some patients may have other tumors like pilocytic astrocytoma. And most of the patients had tumors that either were located on the vermis or were close to the midline. Patients, of course, also have motor symptoms. They also usually have motor ataxia and the presence of hypotonia. Here's an example of a SPECT in a patient with CMS by Dr. Sagyushi in Japan. The quality of the SPECT is a little low. It's an old study of 2001. You can see that first in the post-op day 23, you can see that there are deficits, particularly in the frontal cortex. And you can see in post-op day 68, there are some residual deficits, but there is some improvement. So as you can see, the areas affected actually are similar to what we saw in the aspect of the patient with a right cerebellar infarction. That is why some authors have theorized that they are the same condition or very similar conditions. So this is a quote by Dr. Wells. It is difficult to ignore the similarities between CMS and CCAS. CCAS consists of a set of non-motor deficits that are found in patients suffering from different cerebellar abnormalities and lesions. So in the last consensus meeting of the Posterior Fossa Society, they proposed this algorithm. First, refine the focus. You can see here we have CMS and here we have CCAS. And we need to fine tune the definition of CMS and CCAS. First, by scoring, we need to validate the CMS and CCAS score. The CCAS score, I mentioned it a little bit earlier, it was proposed in 2018. Also, improve diagnosis by neuroimaging and very important prevention in the case of CMS because there has been a large focus on different surgical approaches that can actually diminish the risk. And treatment and rehabilitation. The treatment for this condition is very interesting. There are no drugs specifically for the condition, but some studies have tried some drugs, as we're going to talk in a little while. But rehabilitation is particularly important, and some studies have used a technique called PAS, or paired associative stimulation, to study the effects of transcranial magnetic stimulation in neuroplasticity between the cerebellar and cerebellocortical connections. So the goal here is to be able to do multi-center trials in order to get a larger proportion of patients and get better quality evidence in order to actually do an official guideline that can help us manage these patients. So right now, the approach to diagnosis is clinical. There are no specific criteria, although Hoche and Schachmann actually evaluated a scale to evaluate the most important domains. So what they did is they applied around 70 tests of this wide variety of different tests, including neuropsychiatric rating scale of the cerebellum with CNRS, frontal functions, abstract reasoning, etc. And they applied those to many different patients. So after applying the results to these patients, they then validated the results with other patients and controls. They then use statistical measures in order to quantify the difference between controls and healthy subjects, and they came out with this scale. Okay, so we have these different domains that we're going to evaluate, and we have three different categories. If they fail in one test, that is a possible CCAS. If they fail two tests, a probable CCAS. And if they fail three tests, a definite CCAS. With one failed test, they found that the sensitivity was pretty high, around 95%, but it dropped down to around 45% when three domains were affected. However, the specificity that was around 78% with one failed test improved to close to 100% with three failed tests. Of course, it is important to note that the study was validated. The scale was validated with a very small number of patients, around 55. So that's why we see measures like 100% specificity, which we know that in clinical practice is pretty much impossible. So in the next study, a meta-analysis was developed. In this meta-analysis, some measures were taken in order to ensure that bias was kept to a minimum. Only consecutively evaluated patients were allowed. At least 75% of patients in the study had to have neuropsychiatric testing, and that testing had to be done within 1 year of the lesion in order to establish temporality with the cerebellar lesion. And so they included 10 studies in the final analysis. And what they found was that in most of the measures evaluated, some of the measures evaluated, they included them themselves, and some were taken from the CCAS scale. They found that most of them either had a statistical significant difference between controls and cerebellar patients, or may not, like here. For example, in the trail making test, we can see that the composite of the study actually crosses the midline, so there is no statistical significant difference, but there is a tendency. The studies where they found that there was close to no tendency for a bigger deficit in cerebellar patients were the go-no-go test and the digit span test. So based on all this information, the management of these patients, unfortunately, is unclear because of the lack of multi-center clinical trials. However, some case reports have been done. Actually, in 2019, Dr. Nishida in Japan, in the Japanese Society of Internal Medicine, published an article, a case report of using donepezil on a patient with cerebellar cognitive affective syndrome. If you search, for example, in PubMed or any other library for management of cerebellar cognitive affective syndrome, the results are usually going to be minimal because most of the management or the studies for management of cognitive symptoms in cerebellar patients have actually been done for patients with spinocerebellar ataxias or other global CNS diseases. So some of these studies have shown that anticholinesterase inhibitors and memantine can actually improve cognitive performance. Also, a presentation by Dr. Abrams in the last Posterior Fluency Society presented some evidence of the use of aripiprazole for agitation in these patients and carbamazepine for irritability. So the purpose of treatment for these patients is basically to control the symptoms right now and give rehabilitation, which includes physical rehabilitation, occupational rehabilitation, and speech rehabilitation. And one thing I would like to add at the end is that some studies are currently being done with a technique known as PAS that I mentioned earlier, which is basically based on the concept of Hebbian neuroplasticity. This particular study was analyzing the motor part of the cerebellum, but studies are underway to evaluate the cognitive and affective parts of the cerebellum. So basically in this study, they determined that the cerebellar inhibition time for the motor cortex or M1 was around 5 to 7 milliseconds. So what they did was they did a PAS with the first stimulus, a conditioning stimulus done 10 milliseconds, 6 milliseconds, and 2 milliseconds before a second stimulus was done in M1. Just as a note, M1 does not refer to the middle cerebral artery. It refers to the motor cortex in this study. So as we can see, when the stimulus is before those 5 to 7 milliseconds, we can see that after some time has passed, there is actually a diminishment of the amplitude of the M1 region or the motor amplitude or MEP. While if we do it 2 milliseconds before, once that cerebellar inhibition time has passed, there is an increase in the amplitude. So basically the use of these studies basically wants to use different techniques of transcranial stimulation or direct transcranial current stimulation in order to induce neuroplasticity of the cerebello-thalamocortical networks in order to possibly improve symptomatology in these patients. So, well, thank you all for your attention. Thank you for this opportunity. It was my pleasure to share this presentation with you. And if you have any questions, please let me know. Thank you.